system that would allow us to cross HLA barriers. The one thing you just heard from Dr. Reddy, one of the concerns is creating a disease called graft versus host disease, and it's limited by the numbers of HLA mismatches you can accept when you're using bone marrow or peripheral blood as your donor source. So a number of us around the world explored the possibility of using umbilical cord blood as an alternative. What we found very quickly was that umbilical cord blood, yes, indeed allow us to cross HLA barriers, but the problem was there was only so much blood left in the placenta after baby was born. Only an average of about 3 to 4 ounces of blood that was capable of actually being used to replace or transplant a patient. Well, that worked for children, but it was not always available for adults. So we hypothesized, based on prior information, that by increasing the cell dose, we would actually have an overall outcome that was better than using a single cord blood transplanted unit alone. But let me give you some background data first. So the COBALT study, which was an NHLBI, National Heart, Lung, and Blood Institute study, sponsored this study that took place in children back in the early 2000s. And basically it gave us the results that were pretty much the standard for the day, which demonstrates on the very bottom that engraftment occurred, that is bone marrow recovery, in about 75%. That meant that 25% did not recover. But the overall success, that is disease-free survival at 1 year, was 50%, which was quite comparable to what you saw with bone marrow transplants. But emerging data at the University of Minnesota in my center, really using funds that only came to us through the National Cancer Institute, allow us to do this pioneering work using a double cord blood approach. So you told us something quite different and surprising. In adults, we had 100% recovery of the bone marrow, and overall survival was better than the children, which was unprecedented at that point in time. So it gave us the idea that perhaps we should actually see whether or not using the double cord blood approach would actually enhance the survival in children who had an adequate single unit, but also then could be also studied for using 2 units simultaneously that would automatically increase the cell dose. Makes sense. 1 unit gives you an X number of cells. Simply by adding a second unit would almost double, perhaps, the number of stem cells that we were going to be infusing. Well, so we devised a study where all patients had to be in the pediatric age group that had acute leukemia, that then were randomized to receive a single or double cord blood transplant. What was different compared to the historical group of patients with children receiving cord blood is we used also a different preparative therapy conditioning regimen that prepared these patients for the cord blood transplant, which was what we used in adults. And that comes back to be important to you at the very end when we talk about the conclusions. So patients were either to receive a single or double cord blood transplant. And on the basis of this randomization, 113 were to receive a single and 111 received a double cord blood transplant. And they had relatively similar mismatches between the donor and recipient, but also you can see here that the average number of cells was 3.9 as compared to 7.2. Not quite a doubling, but it's certainly an increase in the number of cells that we hopefully would translate into something more meaningful for the patients. Well, to make a long story short, we came down to the conclusions here, which shows you that there's no real difference in the overall rate of engraftment, comparing the single versus double. But if you recall, we saw a 75% rate of engraftment in the prior study. But you see both arms are actually better. And similarly, when you go looking at graft versus host disease, these were values that were actually not too dissimilar from what we would have expected based on our past history. But you see that although the rates of acute graft versus host disease of 2 to 4 is rather almost identical, and chronic graft versus host disease was almost identical, you see that there is a subpopulation where there is a higher rate of graft versus host disease in the double cord blood transplant recipients. But that's not the important thing. The important thing is really shown here in the next one. We see a very low risk of relapse after cord blood transplant, whether it's single versus double. And then the take-home message is that we found no difference in the overall survival rate between the two, even though the initial hypothesis was, would we see an advantage by receiving more cells? Well, the conclusions are shown here, but one thing I wanted to point out to you is that when we were doing this pioneering work, what we had done is we had changed 2 things. One was we added 2 units of umbilical cord blood rather than 1, and we had changed the conditioning regimen. And what we found was both arms of the study were superior to what we would have expected based on the historical data set, and even concurrent data set that was not part of any other study. So what this showed us is that it's not just receiving a double, perhaps, that had some benefit to some patients, but it was also the conditioning regimen itself that we had changed simultaneously at the University of Minnesota. So it gives you an idea of the complexity of doing these randomized trials. But the bottom line is that we saw an improvement in the overall outcome of transplant for children with acute leukemia. But it also told us a number of other things. And although the survival was not enhanced, what we also showed is that a double cord blood unit was certainly as good as or as acceptable alternative to a single, particularly for those patients that don't have an adequate single cord blood unit based on the cell dose. So it allowed us to extend the transplant experience to primarily adults, which otherwise they would not have an adequate single. And in fact, just a few minutes ago, a paper came out today that I was a co-author on that just came out in Blood First Line edition, came out just at 10 o'clock this morning on adults, specifically looking at double versus single as well. But this was a prospective trial moving forward, looking at whether or not we would see an increased overall survival rate. And what we also learned is that really a difference between a cell dose of 3.9 and 7.2 actually is not an adequate difference for us to be able to detect a change in the overall survival rate. It probably will take a much greater dose escalation to be able to see that. But at least at the end of the day, what we found is that a single cord blood unit should be considered the standard graft for children. But for those that don't have an adequate single unit, certainly a double cord blood transplant will serve as an adequate alternative to a single. And I just want to emphasize once again, you hear a number of studies that led up to this particular trial. Each one was sponsored by either the National Cancer Institute or the National Heart, Lung, and Blood Institute. And certainly this work, which has now led to cures for many patients, adult and pediatric, with a variety of diseases, could never have been translated from the bench to the bedside without the support of the National Institutes of Health. Thank you very much.